There we are. So welcome everybody to the second ECHILD seminar of our series. The last one was in April of this year. The next one's going to be probably around March in 2025. I'm Ruth Gilbert. I'm an epidemiologist at UCL, and you've got a team here from UCL that you can see behind me who are going to be the speakers for today's seminar. We're very glad that this is being done in collaboration with the ADR, Administrative Data Research England Community Catalyst programme, which has recently started for children at risk of poor outcomes, and that's being led by Lucy Griffiths from Wales. So that community catalyst will be conducting reviews, stakeholder engagement, providing training, developing cross-sectoral communities around data for children at risk of poor outcomes. So on this slide, at the bottom, if you want to sign up for more information about the community catalyst, the link is there. And if you want more information about ECHILD or to connect with Milagros, who's the manager for ECHILD, then the links are there. And we're going to provide PDFs of these slides soon after the talk to everyone that's on the list for joining. So don't worry, you will be able to get that, and a recording of the meeting will be available, but that may take a few more days. The meeting will last 45 minutes. We've got 3 talks that are all full, there's quite a lot of material to show, so they're going to be quite rapid, and we'll have that for half an hour, and then we'll have all the questions at the end of after all 3 talks. But in the meantime, please add questions into the chat, and if we run out of time, then we can answer those after the meeting. So don't be shy to put up questions. General information about ECHILD, please look on the website. So I'm going to hand over first to Ruth Blackburn, who's going to give the first talk. So we have to unshare this one and go to the next one. Yep, there we are. So yours is there. And then we go to, oops. This is you. Okay, so I'll share again. Okay. So you might want to hide present. Sorry.
Okay, hopefully you can all see that properly. Perfect. So I'm Ruth Blackburn. I'm going to be presenting today on a study that uses data from ECHILD, which I'll present briefly in this talk, looking at hospital admissions among young people in England who are care experienced and or have special educational needs. So by the age of 18, between 3 and 4% of children and young people have received care under the supervision of the local authority. So they're termed children looked after, or CLA. So as you'd expect, this is a really varied group with complex health, care and emotional needs, as well as disability related needs, and those arising through a history of adverse experiences. So many of these young people who are looked after may also need support for special educational needs. So by contrast, the special educational needs group is a much larger group, reflecting about 1/3 of all school-aged children. And most of this support is given in schools as part of the usual curriculum. However, for some, formal assessment of more complex needs are indicated by an education, health and care plan, or an EHCP. So social care services aim to wrap support around these young people and their families in order to promote their safety, their stability and general welfare. Yet despite these interventions, we know that these young people as a group have poorer long-term health outcomes and also poorer outcomes across education, employment, and a whole raft of other factors than peers who are never care experienced. So really the rationale for this study is that relatively little research has been able to quantify the overlap between these different statutory support groups and to quantify the longer term outcomes for these groups of children. Historically, this reflects a lack of available data which crosses both education, health, and social care services. And this, of course, is one area where ECHILD can help to fill the gap. So in this study, we aim to quantify planned and unplanned hospital admissions during adolescence for children and young people who receive statutory support, either for special educational needs and or who were care experienced. So if there's one thing you take from this slide, it should be a photo of the QR code, although Ruth, as Ruth said earlier, we'll also be sending out PDFs of the slides. So this QR code takes you to our website where you can find resources available for using ECHILD and also resources which are targeted to the public and others who are interested in the data set. So in a nutshell, ECHILD is de-identified child-level longitudinal data that's derived from schools, social care services, and from healthcare services, specifically hospitals. So in the current cut of ECHILD data, we have information on about 20 million children and young people, and the potential to follow these up over time from birth up to the age of 38. In the core ECHILD dataset, which is what we've used for the study that I'm going to present here, we have information from the National Pupil Database. So this is schools data and children's social care data. On the school side, we have information about school enrolment, exclusion, attainment at key stage examinations, and also additional information on special educational needs, free school meal eligibility, and a raft of other factors which you'll get sort of snapshot of information about from the different talks that we'll give today. So critically for this study, it includes information on children who are looked after. On the hospital episode statistics side, we have information on planned and unplanned hospital admissions and also contacts with A&E services and mortality data as well from the Office for National Statistics. In the newly developed version of ECHILD, we have a wider range of data which has come from NHS England. So this includes maternity services data, birth notifications, mental health services data, and community services data, but these aren't included in the talks which you'll see today. So in this study, we defined a cohort of children who were starting secondary school between the years of 2007 and 2011. And they were followed up over time until the last year of the last academic year before the pandemic, which was 2018. So by this time, these children were aged between 17 and 22 years of age. We defined 6 mutually exclusive exposure groups by looking back in time from over the primary school period for children who received special educational needs provision or had a record indicating a need in this area. And we looked at children looked after in terms of whether they had a record recorded before the age of 16. The outcomes that we looked at were planned hospital admissions and unplanned hospital admissions, including the subset which relates to mental health. And we looked at these within age and sex specific strata. So the cohort we identified included about 2.8 million children, of whom about just over half were boys. And within this whole cohort, 36% received any type of support. And as expected, the largest group here was children with special educational needs support only, followed by those with an EHCP, and then those who were care experienced, including the overlap with special educational needs groups. So what this means is that children who were looked after accounted for less than 2% of the study population, but that over 75% of these care experienced children had additional educational needs. Conversely, children who have SEND support or an education and healthcare plan accounted for over a third of the study population, and about 5% of these children with educational needs were identified as being care experienced. So when we look at the rates of planned hospital admissions for these groups, what we can see is that for girls, and the graph here is on the left-hand side, have higher rates of planned hospital admissions than boys for each of the ages that we looked at. And in particular, young people who have an education and care plan had the highest rates of planned admissions. And this is what we'd expect given the likelihood of these groups having higher medical complexity. In general, the rates of planned hospital admissions for groups in the HCP decreased with increasing age, and particularly at the point at which they're aging out of these paediatric services. What's less clear from these graphs is that for boys who are care experienced, some groups in their mid to late teens actually have lower rates of admission than any of the other groups. And this is really important because what we see when we look at the unplanned admissions, which is the next slide, is that these young people have higher rates of unplanned hospital admissions than many of their peers. So focusing then on the unplanned hospital admissions, again, girls have higher rates of admissions than boys, and that it's the groups who are care experienced who have the highest rates, both for girls and boys. What we can see from the girls is that there's a very sharp peak around the age of 14, and this is largely driven by mental health related hospital admissions. And I'll show you more about that on the next slide. So essentially the key takeaway from this slide is that it's the care experienced group who have the highest rates of unplanned hospital admissions, and that this reflects a mismatch with the planned hospital admissions that you saw on the previous slide. In terms of mental health related admissions, particularly for girls, these admissions reflect a significant proportion of the total unplanned admissions. So particularly for girls who are care experienced, around 74% of all unplanned hospital admissions have a mental health related reason for admission. For the boys, this proportion's lower, but still for the care experienced group, it reflects around half or a little over half. So as with the unplanned hospital admissions, rates were very high for groups who are care experienced, but a difference here is that for the subset which are mental health related, the EHCP groups were in relative terms somewhat lower. So the key findings from this talk are that planned and unplanned hospital admission rates were higher for girls than for boys, and this has been seen in other studies as well. Planned hospital admission rates were highest for young people in EHCP groups, and importantly, lowest for care experienced boys in their mid-teens. And when we consider that these groups also have very high rates of unplanned hospital admissions, this indicates an important unmet need for preventative care and early intervention. Unplanned hospital admissions were highest for CLA groups, especially for girls within the HCP, with the exception of the mental health related admissions, which were highest for CLA groups without an HCP group, particularly the girls. And overall, we can see that a significant proportion of all unplanned hospital admissions in adolescents were mental health related, particularly for girls. And again, this really indicates an urgent need for these kind of timely and effective support for mental health related issues, particularly for the care experienced group. So thank you, and we'll move to questions at the end. So I'll hand over now to Ania.
So stop sharing, and then we'll get to measures. Is that yours? Okay, so we're going to share here. Okay, thanks very much, Ruth, for keeping to time. That's brilliant. So we need to put you on presenter. Then we go down here. Right to get to this bit. Over to you, Ania Zylbersztejn. Thank you very much.
Hi, everyone. My name is Ania Zylbersztejn. I'm part of the ECHILD study team as well, and I will present today some of the work that we've done together with my colleague Isabel Ward, who ran all of these analyses on mortality in adolescents receiving special educational needs provision and or social care provision. So just to give you a bit of background and rationale for this study, it is known that adolescence is a key formative period when young people experience rapid physical, cognitive, and social development. And it's also a time of multiple transitions happening in their life where young people move from out of secondary school and between pediatric and adult health and social care services. So this can lead to less structured support for young people as they become more independent. And in this study, we really wanted to know what are the outcomes of young people who are known to services as they might be receiving less structured support. So as you heard from Ruth, it is established that 1 in 3 children in England receive some special educational needs provision at least once during their time in school. And as you will hear from Matt in the next talk, 1 in 4 children ever receive any intervention from children's social care services before they turn 18, and about 3 to 4% of all children are ever looked after. So these are the groups that we were interested in this study, and our objective was to examine the risk of death in adolescents who receive any statutory provision, so either special educational needs provision or an intervention from children's social care services compared to their peers. And in this study, we used ECHILD to develop a cohort of young people who were enrolled in state-funded school in year 9 between 2009 and 2014 academic years. And we used their data prior to enrollment in year 9 to identify whether they received any special educational needs provision between year 3 and year 9. So this could be either SEND support or an EHCP. And we used information from children looked after return data and child in need data to identify children who received any social care intervention. The follow-up was through linked HES-ONS mortality records. So we examined the records from year 10 until 31st of December 2020. And we were interested in all-cause mortality, but also in cause-specific mortality, which we grouped as deaths due to injury. So that included adversity-related injuries, suicide, homicide, drug or alcohol-related injuries, as well as accidental deaths. Non-injury deaths, which were all other deaths with a recorded cause of death. And then we examined separately deaths which had a missing cause of death, as this could be due to issues with recording of causes of death during COVID pandemic, as well as known problems with linked HES-ONS mortality records where causes of death might be removed. Okay, in interest of time, I'll move to results. So our cohorts included over 3 million pupils, 49% of them were girls. Over 56% had no indication of special educational needs provision or a social care intervention. 30% had a record of receiving only SEND provision, and the dark green here indicates 2.7% of children with an education, health, and care plan. Under 5% of children had only a social care intervention, and 9% had both. And our study included over 6,000 deaths. 2/3 of these deaths occurred in boys, and the figures here present cumulative risk of death in boys on the left and girls on the right. And apologies, the very top number should say 1.2% rather than 0.12. But you can see from these figures that across all groups with all levels of statutory support, boys had higher mortality than girls. The group with the highest risk of death among both boys and girls were young people receiving both social care intervention and having a recorded SEND provision. Boys with both of these had 5 times higher risk of death than their peers with no statutory support, and girls had 6 times higher risk of death. For both boys and girls receiving only a children's social care provision, the risk of death was 3 times higher compared to their peers. And the risk was higher also for children who received only SEND provision. And we then were interested in examining cause-specific mortality. So the figure here shows mortality rates for non-injury deaths in light blue, injury-related deaths in orange, and mortality rate with missing causes of death in dark blue. And you can see that, non-injury deaths accounted for the largest proportion of all deaths. Over half of them were due to non-injury, and the rates were highest amongst people receiving both social care and special educational needs provision. And the rates of non-injury mortality were also higher for boys and girls who received only an intervention from social care. And then looking at injury-related deaths, which are marked in orange here, 1/3 of all deaths were indicated to be injury-related, and you can see that the bars are much larger for boys than for girls, indicating that boys have higher rates of injury-related mortality, and in particular, young people who had a record of social care involvement had over 3 times higher risk of death, irrespective of SEND provision, compared to their peers with no statutory support. So in this study, we found that overall mortality rates are significantly higher for young people who receive any type of statutory provision. Children who receive both a social care intervention and SEND provision had the highest risk of overall mortality, and this was largely driven due to non-injury mortality. Rates of injury-related deaths were higher in boys compared to girls, and overall they were highest for young people who received any social care support. So we are hoping that understanding the patterns of 10-year risk mortality in adolescents receiving statutory support will help us inform interventions to prevent future deaths. Thank you.
Thank you very much, Ania. So keep your questions coming in on the chat, and we'll go to Matt. That's you, isn't it?
Yes.
The last one, and we should be able to just hand straight over.
Yeah, thank you very much.
Yeah.
You want
I can't
to?
find the cursor.
Where's it gone? It needs to be here.
There you go. Thanks.
My presenter view. There you go.
Lovely, thank you very much. So I'm Matt Joan, a research fellow here at ICH, and I'm going to present some results looking at school non-enrolment and school exclusion among children with social care and special educational needs. And I'm also going to explain how we arrived at that 1 in 4 figure, so 25% of children ever receiving social care, because obviously it's quite a striking figure. And I'm going to go through this really quite quickly to try and make up some time, make sure we've got plenty of time for Q&A, but everything here has been published and the links are in the end of the slide, so you can follow up with detail later. So exclusion from school is self-evidently a bad thing, and it's also associated with poor outcomes later on across life. And rather concerningly, children with social care involvement, we know they are more at risk of exclusion in any given school year. So here on the graph, we have data from Department for Education, the latest stats available, showing that about 2 to 3% of all children are excluded each year. Here it's fixed term, and more rarely permanent exclusions. But then children with social care defined in various different ways here. You can see all those lines are along the top, between about 10 and 15% of children excluded each year. What these figures don't show you, of course, is the interaction with special educational needs, and they don't show you the cumulative, what percentage ever are excluded across school. The other thing we're looking at here is really off-rolling, which is essentially the illegal exclusion of children. It's where a child is removed from a school without using the lawful permanent exclusion process, and where that exclusion, or that removal rather, is in the interest of the school and not of the child, for example, to avoid costs. Now, because it's clandestine and essentially illegal, there are no official recorded data on this, but we used the non-enrolment from the NPD as a proxy of off-rolling, as a proxy of otherwise not getting an education. So before going into those results, I'll just explain how we arrived at that 25% figure. So we used the Child in Need census. The problem is that it only began in 2008, and so we don't have a full 18-year cohort that we can follow up. And the first few years are of quite poor data quality. And so we're able to stitch together, what we had to do was stitch together 3 different estimates for 3 different cohorts and account for less censoring. And the bottom line was 25% of children being recognised as a child in need, so being a child in need plan and ideally receiving services. But before we get there, we see that a third of children are referred and assessed by social workers, and 7% are on child protection plans, so at risk of or experiencing abuse and neglect. So moving now back to the exclusion and the non-enrolment results. So to do this, we adopted a longitudinal design using the NPD linked to the social care data, and included everybody enrolled in year 7, so age 11 in 2011 and 2012. That's just over 1 million children. We look back for their exposure data, particularly their social care and their SEN records. And then we look forward into Key Stage 3 for the cumulative exclusion there. And then we update the analysis, including the exposure measurement up to the end of year 9, and look for exclusions in Key Stage 4, so years 10 and 11, the final 2 years of schooling. And what we find is that 13% of all children received at least one fixed-term exclusion or permanent exclusion across secondary school. And of course, this was much higher among children with social care, so 32% of all those in need, and 40% of children on child protection plans or looked after. And then 2 graphs, the one on the left is for Key Stage 3, the one on the right is for Key Stage 4. The red line is for children with a history of SEN provision, the blue without, and each dot is each of those social care groups. And what you can see quite clearly is that it's children with both social care and SEN provision who are most at risk of exclusion. So in Key Stage 3, for example, over 40% of children looked after who also had SEN history were excluded just in those 3 years. And there's also lots of geographical variation, mostly between local authorities, which we weren't able to explain with the individual level variables, things like gender, ethnicity, deprivation in the model. So it's likely to do with school factors and social care factors. Moving on then to non-enrolment. So we adopted essentially the same approach using the same cohort, but here we only looked at Key Stage 4. And that's because when we looked at non-enrolment in Key Stage 3, it was more associated with ethnicity and language and much less so with deprivation. So we think that's probably more a case of children essentially leaving the country or going to private schools, whereas in Key Stage 4, it was very much more to do with deprivation and social care and SEN history. So overall, 3% of children were not enrolled in Key Stage 4. Having been enrolled, of course, in year 7, so they disappear from the NPD, from the National Pupil Database. And that rate was higher among children in need at 6%, and then 8% for those in child protection plans, 11% for children looked after. And again, it's those with both social care and SEN history who are most at risk. And again, there's lots of variation largely between local authorities. There may be something going on in London as well, where the rates seem to be a little bit higher overall. So to sum up, children with social care history, and especially those with SEN provision, were between 2 and 3 times more likely to be unenrolled in Key Stage 4, and between 2.5 and 3 times more likely to be formally excluded compared to children without those statuses. And there's a large amount of variation that, as yet, we've not been able to explain, something with individual level variables. It's really important to note, though, that becoming unenrolled from the NPD does not necessarily mean off-rolled. It could be emigration, it could be transferring to private or homeschooling, death, which of course is very rare in this age group, or otherwise not getting an education. When we did this work, we didn't yet have the health linkage. Now that we have that, we could replicate this analysis and look for activity in the health data, and of course also link to mortality data. We don't have any data on the unmet social care or SEN need, or indeed any data on the actual services provided. And as we've mentioned already, these are very heterogeneous groups, and kind of grouping them in essentially, no SEN versus SEN, or these 3 broad groups of social care, is going to be masking a lot of what's going on. As I say, all the links are here so you can follow up, and thank you very much.
Thank you, Matt, and thank you, team, for keeping to time. So we're back on time, but we haven't we need to look at all the questions in the chat. So while we're looking at that, and the team here can help me. Are there any questions? Please put up your hands, and we can take a question from the audience. So there aren't any questions from the audiences. So we've got one from Tanisha. Hi, does non-injury deaths include deaths from suicide or mental health problems? Ania?
Hi, that's a very good question. So no, those deaths would be suicide would be included as an injury related death, because we included sort of intentional and non-intentional adversity there. And mental health problems would also be included I would need to check actually if that's including the adversity related definition.
Yeah. A main cause of non-injury death, Ania?
On top of my head, I want to say cancer or epilepsy. That would be the two sort of the neurological conditions, and cancers are the two chapters that appear most frequently.
Yeah, and slides will be shared. I said that at the beginning, so a PDF will be coming round. So we've got more questions about deaths. Can I ask which are the main reasons of injury and non-injury? I think we've covered that. Are you linking in with the NCMD team who have details on the cause of death? So I think you mean the National Childhood Mortality Database. No, we're not yet linking in with that. That is an external database that's not provided by NHS England. And certainly I think those sorts of registry databases is something that we could consider in the future of ECHILD, but we're not at that stage yet. So thanks for raising that. Damos, are you able to break down the reasons for planned and unplanned hospital admissions further? Ruth?
Yeah, so we are able to look at the ICD-10 and the procedure codes, which are recorded within each hospital episode, and a series of episodes make up an admission. I haven't actually done that for this analysis, but it is something that we could do. Essentially, what we'd probably be doing is then you can look at either the primary reason for admission or up to 20 other codes, which are could be grouped according to the ICD-10 chapter under which they're looked at. So good idea. We could do it, but we haven't done it yet.
Thank you. And another question about deaths from Emma. So this is about whether intentional self-harm, so I think you mean suicide, Emma, is included. You're saying it's the leading cause of death for 5 to 19-year-olds. So those are being classified, I think, in the injury category. Yes, thanks. Then does non-enrolment include homeschooled data?
Yeah, so it would do. It's very difficult at the moment to find information about even the numbers of homeschooled children. The last number I could find for a good number of years ago was about 55,000 children. Many years ago, even before the change of government, DfE were running a consultation on setting up a register of homeschooled children. And in the 2024 King's Speech, the government introduced the idea of a children's welfare bill, which will include a children not in school register. Hopefully that will be linkable to the NPD, so we could then follow up children in those settings. But at the moment, what I just showed you today, yes, they're in there in the non-enrolled group, but they're a relative minority.
So question from Tanisha, yes, statements are the old version of EHCP now, so they're in ECHILD and that's all listed in the user guide. Amy, the exclusion project, this is you, Matt, what benefits were there to having ECHILD as a resource? I think you explained that. Yeah,
so we didn't have it at the points actually. So now we would be able to look at health outcomes, for example, of children excluded or not enrolled.
So how do you define a CSC? This is from Charlotte. Is it any interaction with CSC? Do you want to just clarify?
Yeah, so I think we all define it in the same way. So it would be a child in need. So someone who has been recognised, referred to social care, assessed by a social worker, and then the social work team has agreed that child is indeed a child in need, which could be all sorts of things, but they'll put them on a child in need plan typically, which could involve all sorts of different services. all sorts of different reasons for that as well. It's a real mixed bag. But it's children recognised in the child in need data set as a child in need.
And can you just cover placement type? A question from Charlotte, please.
Yeah, so all types were included, so residential homes, foster care, kin and non-kin. Those are certainly the main ones, and being looked after at home under a care order as well is included in that, which is about 7% overall.
And Richard asks whether the ECHILD database, it doesn't currently link to DWP-HMRC data, and has there been any work using ECHILD looking at the impacts of poverty? So in ECHILD, we have free school meal status as well as deciles of index of multiple deprivation and the IDACHI version, which is for children. But we don't have DWP-HMRC data. I think it would be extremely important to have this as to give us information on strata of household income, so not just free school meals, which is the benefit level, but strata right across the whole income distribution. And of course, we'd have employment data from HMRC. We're a way away from that being possible, but please keep asking this question. And I think it's very important to be able to understand the impacts of poverty. For instance, other work is showing that there's very steep gradients in school attainment within every quintile of IMD. So you really miss lots of the steep gradient if you only have IMD and free school meals. So from Emma again, are there differences in London? Are the differences in London possibly related to higher rates of parents who move abroad?
Yes. Yes.
Yep. Okay, and are there plans to link ECHILD with primary care? Again, David, keep asking this question. Of course, primary care is a huge gap in health problems. So Matt has just shown that 25% of all children will have chronic health conditions by the age of 16 recorded in hospital data, but it's likely to be higher if we had primary care data, and there's many chronic conditions that are only managed in primary care that we miss. So that's well understood, and it's really important to have primary care data. But look, this is great. It's now open for access to researchers across the UK and to government. We're taking small steps forwards, but yes, this is an important thing to have our eye on for the future. Can we observe free school meals for children before age 5? This is a niche question.
Don't know.
Potentially in early years census, but then not all children will be included.
Yeah.
It's worth saying in the NPD that only includes free school meals for children that receive it on or would receive it on the basis of income, low income. So even for where it's universal, the data is only on those where it would have been on the low income basis. But I don't think we've really, I mean, I've definitely not looked at the preschool years.
No.
Right. So thank you, Kate, Lewis. You haven't seen it in the early years. Thank you. Right, we've got through your questions as far as I can see. Are there some hands up? Am I missing it? But please, we can take some other questions. Here we are, Damos. The pupil, thank you for raising this, Damos. So the pupil parent match data is limited in a few ways in coverage, being dependent on child benefit uptake. Is there any plan for each child to build up a parent pupil match and matching variables about household composition, income, etc.? So there's several factors here. In a moment, I'm going to ask Damos for you to explain this database to everyone else. But first, I'll ask Katie Harron, who's the director of ECHILD, to just explain what we do know about households and families in ECHILD. And then I'll come over to you, Damos. Katie.
Yeah, so in ECHILD, we can link together mothers and their birth children via their hospital delivery and birth episode records. So that means that we can link together siblings of the same mothers, which gives us a nice opportunity to look at members of the same household, although obviously we'll miss half siblings and we don't have information at the moment on the father. although we are hoping to be able to link UPRN, the unique property reference number, into ECHILD, which would then give us people living in the same household, including potential father figures. We haven't yet got the PPMD data within ECHILD, but yeah, it would be interesting to hear more about that.
Demos, do you want to tell us about PPMD? Can he be unmuted?
I just managed to
Yes.
unmute. So I wouldn't consider myself by any means an expert, but it basically I think on the back of child benefit linkage can tell you things about number of parents in a household stability, siblings, and household income, and one of the issues is coverage is a bit limited, and it sort of gets worse as you go up the income distribution because of that child benefit dependency. If I was going to give you any more detail on it, I'd simply be Googling it so that I could read it out and sound better informed. So I'll let others do that. But it's that limitation that I'm just after a kind of a more sustainable solution to. And yeah, it struck me that if we could use ECHILD as a bit of a scaffold here, and yeah, bring in maybe some additional things, but it's great to hear what we already can do. So thanks for the answer there.
Thanks very much, Demos. And I understand it's only since 2017, I think PPMD has been put together. Is that right? I mean, I think, there could be a strong argument for some just early developmental work looking at the linkage, the quality of linkage and who's missed, so that we could sort of really understand how useful this might be to make available for wider use. So yes, watch this space and keep asking the question. Now we've got David. Will a recording be made? Yes, I said that at the beginning. Yes, there will be a recording, might take a week, and the PDF will be sent round later today. Are there any more questions?
There was a sub-question about fields in the death data. Let's go up a little bit. It was made a sub, that one, never mainly. Include all the fields.
Yes, so the short answer is yes, it's all 20 plus. I cannot remember exactly, but it's the underlying cause of death and then neonatal and non-neonatal causes of death.
Yeah. Okay, well, we're almost at time, unless there's any last urgent question. Oops, one more, someone typing rapidly.
Okay. It's a very easy question, but a complicated answer. It depends on whether they have a pupil matching reference recorded or not, which is primarily of school-age children. So if a child does not have that, so they're very young, for example, they get assigned a local authority ID that is only valid within that authority. So if they move, no, you cannot track them. They might have records when they're very young, and then more records when they're a bit older, when they're in school, in the same authority, then you can link those records. But otherwise, no. The PMR is nationally unique, so it follows them around the country.
Yes, that is a important limitation for the youngest and the oldest, who tend to not have a PMR.
Yeah, and in the preprint that's I linked to in my slides, we show that actually it's 90% of the records of school-age children have a PMR, meaning 10% don't. So even of school-age children, there are some who don't have a PMR. So it's always important to bear that limitation in mind. There's a linkage error, essentially.
Okay. Well, thank you everyone for attending, and a big thank you to Katie Harron and Milagros Ruiz, who organised this meeting together with Lucy. Lucy, do you want to very quickly add anything about your catalyst?
No, thanks, Ruth. Brilliant presentations, and if anyone would like more information on the catalyst, then the link will be in the slides. Thank you.
Thank you. All right. Thank you. Until next time, and do get in touch if you have further questions. Goodbye.